Hi, so welcome everybody to the Collaborative Northwest latest meeting, which is a Christmas special on the subject of ketamine. I can't see myself, so I'm not sure whether you can see me, but I'm sat here wearing my Christmas hat for the occasion, and it may appear in a sec. So this is quite an eagerly anticipated topic. I know the group have a lot of information to get through, so I'm going to keep our little introduction quite short to give them time to get on with that. So Alison especially was quite keen to kind of have a festive theme to that, so I hope some people have mince pies or a Yule log to kind of celebrate the occasion. And I thought, what would be better than a cheesy Christmas cracker joke? So, why did Santa have to go to hospital? Because of his poor elf. And while the collective region kind of comes together in cringing, hopefully I'll move on before I get any more embarrassed. So, I think first you wanted to briefly reflect on what's been a very challenging year for everyone in the healthcare setting, I think, and not least in palliative care. This was a snapshot we did as an interactive piece at the launch meeting at the start of the year, and I think it's likely that these themes that people were feeling at the time haven't really changed at all, and are possibly even more kind of acutely felt, really, and that's had a huge effect. And with when there's clinical pressures, that affects kind of the non-clinical work as well. And I think that's what we've felt sometimes with Collaborative. And we've had quite a frustrating time really trying to get some of the guidelines that a lot of work has gone into over the line and published. With one of the particular challenges being with getting external reviews and people to give their time to do that, to kind of have the nice accreditation. But we've had some good news as kind of an update from the Collaborative point of view, is that we've had some guidelines published kind of within the last couple of weeks. We've had guidelines on the assessment and management of fatigue being published pending external review, but for people to use as soon as possible, and guidelines on anticoagulation as well. So that's a really exciting development. I hope people will be beginning to access these and use them. As I said, there'll be updates when these get their kind of external review and formal NICE accreditation, but we thought it was important to give people something to kind of begin to use. And there's a number of more guidelines that we expect will be able to go live on the website very, very soon. So keep a close eye on that. And looking forward to 2022, the work of Collaborative will be ongoing, and we're going to be giving people the opportunity to kind of shape the future really of the work across the network and regionally. And we've also got regular meetings restarting from March. So it's as important as ever to keep up to date with what we're doing, so you kind of know about these. You can sign up for email updates via the website if you haven't already, so that's at the bottom of the page, and also following on Twitter, and I believe there's now a very good number of followers on there, but for updates about what's going on. So I said I'd keep my bit brief, and hopefully I have done so. Now be able to pass over to the ketamine guideline development group, project managed by Penny, who are in Marie Curie. So if I come off my screen and stop sharing, hopefully we can hand over to them.
Thank you, Tom. So I hope you can all hear me okay. And thank you to everyone who's logged on for coming to hear our update for the ketamine as an analgesic in palliative care guideline and our audit results. So I've been very lucky to be joined in the group by all of the members listed here. As you can see, many of us are based at Marie Curie, but we've also had some representation from the community in North Liverpool, from Clatterbridge, and from the Royal. And also we've had two invited experts who are both consultants in palliative medicine in Edinburgh, Dr. Barry Laird and Dr. Duncan Brown, and Mary Worthington as our patient and public representative. So this is a summary of what we're going to be running through today, following the usual lines of these audit presentations. So Amy will be taking us through the summary of the 2012 guidelines and the literature search. Laura Chapman will be taking us through the literature review results, Sinead and Johnny taking us through the audit results. I'll come back to take us through some of the highlights of the proposed standards and guidelines. Unfortunately, our invited experts can't be with us today, but we will then move on to Mary Worthington, who has some initial thoughts for us.
Penny?
Yes.
We just have an issue seeing the slide presentation. Is that sharing okay on your screen?
It is on our screen. Are you still on the initial slide?
No, we can just see you. So is it on the shared screen mode in the Teams meeting as well?
No.
Hold on. We'd hope the technical difficulties were over, but it looks like that's not the case. So.
Sure, it's a brief one. Okay. There we go. Looking good.
Okay, except I can't see it, but let's see. Okay, so can you still see it?
Yeah. We can see presentation. Yeah.
You've done. Yeah.
Yeah.
Okay. Thank you. Let me know if there are any other problems. So before we move on to that, just a very, very quick recap about ketamine. Not going to go into any great detail, but it is a general anaesthetic. It blocks at the MDA receptor, and at sub-anaesthetic doses, it's used as an analgesic. It is also used in depression. Quite a few studies about this recently, but we have not looked at this as part of this guideline. And I wanted to very quickly mention about some of the different types of ketamine, just to explain a part of the literature search. So there are two different isomers, S and R ketamine. S ketamine is more potent, and the mixture that we use in our everyday clinical practice is racemic ketamine, which is a 50-50 mix of the two. So that's all I wanted to mention about ketamine. And I will hand you over to Amy to go through our current standards and guidelines.
Thanks, Penny. So I'm not going to spend long going through the current guidelines because hopefully everyone will have seen them prior to this meeting. So the guideline we've been reviewing was written in 2012. It was primarily level 4 evidence and contained the following subheadings. Just as a highlight on the current 2012 guidelines, so the focus was primarily on burst ketamine, as that's what there seemed to be the most evidence for. And we'll go into this a bit further in our review. There was also some advice on blood pressure and pulse rate and how that should be monitored during dose titration of ketamine. So just looking briefly at the standards of the 2012 guidelines, and we will be referencing these when Johnny kindly goes on to present the audit results later in this talk. So the first standard is about documentation, clearly in case notes. There's advice on what should be measured and monitored during ketamine titration. That sodium chloride should be the diluent and ketamine should always be prescribed in milligrams. And then some information on discharge. So there should be a named contact for further advice. There should be information that's given to patient, GP and community pharmacist. And there was a time set for follow-up for patients who are on ketamine with a specialist in palliative care. And this was suggested to be monthly in the 2012 guidelines. We'll go on to talk a little bit more about that later. And it was also a standard 8 that each unit should have a policy for the use of ketamine. Just moving on to the literature search. So in the launch meeting earlier in the year, we got some opinions from everyone who attended on what they would like to see reviewed this year with regard to the ketamine guidelines. and we came up with the following PICO. So in cancer and palliative care patients with complex pain, what is evidence is there for the use of ketamine as an analgesic in relation to safety and efficacy? So hopefully we're going to be able to answer that with what we've suggested today. So our inclusion and exclusion criteria for the literature search was decided by group consensus. So we included anyone over the age of 18. We included people who had cancer or palliative diagnosis and those who had complex pain. The exclusions generally were review papers, case reports, non-analytical case series. There was also a lot of papers on perioperative use and enhanced recovery pathways involving ketamine. There was some interventional pain procedures, lots of papers on sickle cell crisis. And as Penny mentioned earlier, with ketamine also being used for depression, there was lots of papers that we excluded because that was the primary outcome and it wasn't looking at ketamine as an analgesic. Later, when we came to full text review, we also decided by group consensus to exclude intravenous administration of ketamine and any forms of ketamine that weren't racemic ketamine because it's not relevant to our use in palliative care. And just as an overview of the literature search results, so our MASH terms are in the box on the left-hand side. We got a return of 753 papers in total, but when we excluded based on abstracts, titles, duplications, we were down to 23 papers for full text review. You can see under there the numbers that were excluded and the reasons why. And that left us then in the end with a total of 10 papers. So I'm just going to hand over to Dr. Chapman for some further discussions about the literature review.
Thank you. So just to refresh your memories really, these are the levels of evidence that we use in Collaborative Northwest, just to grade the quality of the studies that we're looking at. And we'll be making reference to those in our literature review. So I'm not going to talk through all of these in detail, but these are just some of the uncontrolled studies that we looked at. The first one there talks about ketamine in the management of refractory cancer pain in a palliative care unit. So these were 70 cancer patients receiving ketamine between 100 and 300 milligrams a day via syringe pump, with a 74% effectiveness rate. And one of the conclusions here was that response and fewer side effects may be seen at lower doses. Then Mercadante et al. Looked at ketamine in a palliative supportive care unit, and this was a retrospective analysis. Again, these were patients receiving ketamine 100 milligrams a day via a syringe pump, and all of these patients had midazolam as standard, effective in 75%. We then come on to a strategy for conversion from subcut to oral ketamine, and this was testing whether a 1-to-1 ratio would be safe and effective. This was a prospective before and after study looking at just 29 patients with neuropathic cancer pain, and they concluded that in the majority of patients a 1-to-1 ratio was indeed safe and effective. Cannon et al. Looked at oral ketamine again, and this was as an adjuvant to oral morphine for neuropathic pain in cancer patients. So this was a very small number of patients, only 9, and they received oral ketamine, which was effective in 77% patients. And the Jackson et al. Study is, I think this is the study that probably informed our previous standards and guidelines from 2012. So this was an Australian study looking at the effectiveness and adverse effects profile of first ketamine in refractory cancer pain. So this was an open label multi-center study carried out in 8 different places. And it looked at the different doses of burst therapy that I think probably quite a few of us are familiar with. So starting at 100 and escalating over 3 to 5 days to 500 milligrams via a syringe pump. it did show some adverse effect and more on higher doses, but it did also show a 50% response rate. And then moving on again to Fitzgibbon et al. So this is looking at parenteral ketamine as an analgesic adjuvant for severe pain. And they looked at just 16 patients, and this was a combination of subcut via a syringe pump or IV ketamine, and found effectiveness in 69%. So there are more studies, and there will be full details of those for you to look at. But I think what we can get from this review is just how heterogeneous the group of patients were, and also the dosing regimen used. From these, there seems to be a broad conclusion that lower doses and slower dose increments can be associated with mild and infrequent adverse effects. And there was also comment on the urological adverse effects, especially at higher doses, and that these may be long-lasting. So looking at randomized controlled trials, so this study from Hardy et al. From 2012 used the same regimen that was used in the Jackson study. So this was a multi-site, double-blind, placebo-controlled trial. So they looked at ketamine administered via a syringe pump over 5 days, and that was similar to the Jackson study, looking at between 100 and escalating to 500 milligrams. Though large number of participants, 185, and some quite interesting results from this one. So twice the number of adverse effects in the ketamine group. Some of these adverse effects were quite serious. So there was quite a few site reactions. There was one bradyarrhythmia. There was one cardiac arrest. Interestingly, they found no difference in the response rate when looking at pain at 5 days, and a very high placebo response rate of 27%. So they looked at the number needed to treat, so that's the number of people you would need to give ketamine to have a positive effect, and that came out at 25. Number needed to harm, so the number of people you would need to give it to cause an adverse effect, was only 6. So their conclusion was that ketamine does not have net clinical benefit when used as an adjunct to opioids in cancer pain, and that's one of those powerful studies I think we looked at. We gave that a rating of 1+. And then a study by Fallon et al. From 2018, and part of the group who carried this study out was Barry Laird, who's one of our external experts. So this was a multi-site, double-blind, randomized controlled trial of oral ketamine versus placebo in patients with cancer-related neuropathic pain. And whilst it's cancer-related pain, a lot of these patients actually had cancer that was in remission, and it was neuropathic pain as a result of chemotherapy. So a large number of participants, again, 214, and they found that ketamine was equivalent to placebo. There is comment that they got a feeling that it was beneficial in a subgroup of people, and that maybe we're just not that good at identifying who that subgroup is. So they've recommended further studies to focus on central sensitization as perhaps a marker for who might benefit from ketamine. And then the Cochrane review of ketamine as an adjuvant to opioids for cancer pain. This was updated in 2017. It's been carried out twice before. Clinical trials were searched on the addition of ketamine to morphine-like drugs for cancer pain. There were 2 studies that had been commented on previously, and 1 new study. And 3 studies were all very different, so different doses, different routes, subcutaneous, IV and intrathecal, and different durations. And because of this, it wasn't possible to carry out a meta-analysis. The key results were that 2 out of the 3 studies reported a reduction in pain, but it was commented that this could be due to chance because the studies were so small. So the conclusion was the current evidence is insufficient to assess the benefits and harms for ketamine for this use. The evidence is of low quality, and rapid dose escalation to high dose ketamine, by that we mean 500 milligrams per 24 hours, doesn't appear to have clinical benefit and may be associated with serious adverse events. So unsurprisingly, they've asked for more RCTs examining specific low-dose ketamine. And just to briefly touch on the 7th edition of the palliative care formulary. So there's a lot of detail in here relating to the different treatment regimen for ketamine, but they do make comment about the use of high-dose burst ketamine via continuous subcutaneous infusion, stating that the results of the studies they looked at suggest that rapid titration involving such doses of ketamine is generally inadvisable. So I'm sure we'll come back to those in our discussion later. Now I'm going to hand over to Sinead for the audit results.
Thank you, Laura. Next slide, please. So for those who completed the healthcare professional survey, most worked in a hospice setting and most were doctors. Next slide. And 45% of responders have worked in the palliative care setting for more than 10 years. Next slide. And as we can see, 50% of responders have looked after 1 to 3 patients who required ketamine in the last 12 months. Next slide, please. So this was a multiple choice question. What regimen is prescribed in your practice or place of work? So we can see that most responders used a syringe driver to deliver their ketamine, followed closely by oral ketamine. And what influenced their practice was success of past experiences. Next slide, please. We looked at prescribing of ketamine and non-medical prescribers, and 62% of non-medical prescribers said that yes, they would initiate a prescription for ketamine following the advice from their consultant. 87% said yes, that they would increase the dose of ketamine already prescribed following advice from their consultant. And 13% said that they would increase the dose of ketamine already prescribed without gaining advice from their consultant. Next slide, please. So tying in with Standard 8, nearly 50% of responders have a policy for the use of ketamine as an analgesic within their trust or organisation. Next slide. And for those who do not have a policy, they indicated that their practice was guided by the Collaborative Clinical Standards and Guidelines, support or advice from their palliative medicine consultant, the PCF, or SIGN guidance. Next slide, please. So just over 35% of responders indicated that their trust or organisation use a formal observation or monitoring chart, which is different to the News 2 chart, to document observations when a patient is prescribed ketamine. Next slide, please. We asked about patient information leaflets, and nearly 30% of responders indicated that their trust or organisation have a patient information leaflet regarding the use of ketamine for complex pain management. Next slide, please. And 15% of responders indicated that their trust or organisation had an information leaflet for other healthcare professionals if the patient was transferred to another care setting or discharged home. Next slide. We asked about issues obtaining ketamine on discharge or in the community, and the majority of responders said that sometimes they had issues, and reasons for this was due to GP reluctance to carry on the prescription or limited or no stock in local pharmacies. Next slide, please. So we asked you to score out of 100 how effective in your experience is the use of ketamine in the palliative care setting. And the mean average score for this was 65. And as you can see, some of the reasons for this was because it produced mixed results, that it could be patient dependent or cancer dependent. Some felt that it worked for some patients better than others. Next slide, please. The mean average score was 67 when we asked you to score out of 100 how well tolerated ketamine is for patients in the palliative care setting. And reasons for this was that it is usually well tolerated but not always effective. The side effects were usually mild and manageable, and lower dose oral ketamine is usually much better tolerated. And one person had commented that their experience was that some patients tolerated burst ketamine at traditional doses very poorly. Next slide, please. And finally, we asked if there is enough evidence to support the use of ketamine for complex pain in palliative care. And yes, 39 respondents said yes, and 37 respondents said no. I will now hand you over to Johnny to present the results of the case notes.
Thank you very much, Sinead, and thank you very much to everyone who contributed to our healthcare professional and case note surveys. We looked at 79 episodes of ketamine use for patients from across the region. There was an approximately 50-50 male to female split, and the most common age of these patients was in the bracket 50 to 59. They most commonly had a malignant diagnosis, and the most commonly occurring etiologies were gynecological, respiratory, and lower GI. These were mostly hospice patients receiving ketamine therapy for the first time, although where they previously had an episode of treatment with ketamine, there was a wide range of time since that last episode. We divided the survey questions regarding documentation on ketamine into 3 phases, and first we'll look at the pre-treatment phase. The indication for ketamine therapy was usually neuropathic pain or complex pain, and patients were, in 90% of cases, taking both an opioid and a neuropathic agent, alongside a variety of other therapeutic interventions. This slide relates to 2012 Standard 1, which recommends that the decision to commence ketamine, its indication and intended regimen should all be clearly documented in the case notes. And there was this commonly happened. There was less documentation relating to a discussion of risks and benefits with the patient or the next of kin, but that's not to say that this didn't occur. This data relates to 2012 Standard 2, which recommends that prior to commencing ketamine, the heart rate, blood pressure, respiratory rate and pain score should be recorded, and that occurred in 2/3 to 3/4 of cases. Most patients received CSCI burst ketamine, while half patients received CSCI burst ketamine, with the remainder fairly equally divided between the oral route and longer-term CSCI maintenance ketamine, which we're now referring to as lower dose titration CSCI ketamine in the updated guidelines. Next, we'll look at the treatment phase itself. And this table shows the starting and final dosing frequency, along with the titration time to final dose for the 3 most commonly used administration routes. For oral ketamine, most patients received 10 milligrams TDS to QDS. It was difficult to identify from our data the exact final dose and frequency, but titration generally took place within 2 weeks. For CSCI burst ketamine, all patients started at 100 milligrams per 24 hours by a syringe driver and titrated to a final dose of 500 milligrams per 24 hours in 2/3 of cases. About a quarter of cases titrated up to 300 milligrams per 24 hours as a final dose, and this exclusively took place within a period of 5 to 6 days. The data on CSCI slower titration ketamine was harder to interpret, mainly because about a third of patients converted to this regimen from another regimen, but about 2/3 started at or just lower than 100 milligrams per 24 hours. The final dosing frequency for this means of administration was 200 to 250 milligrams per 24 hours in a third of cases, and 100 to 150 milligrams in a quarter of cases. Titration times were, there was a wide range here, from just a couple of days to several weeks. This slide relates to 2012 Standard 3, which is that sodium chloride should be used as the diluent for injectable ketamine. And this was the case, which was documented as being the case in about 50% of patients receiving the CSCI burst regimen, and about 90% of cases receiving the slower titration regimen. 2012 Standard 4 recommends that ketamine should always be prescribed in milligrams, and this was the case in the overwhelming majority of cases. The data here refers back to Standard 2 and the frequency of, rather the type and frequency of checks taking place during ketamine therapy. And adherence to this recommendation was similar as it was at the start of treatment. It wasn't possible to say which clinical setting the patients were in when undergoing these checks, or how frequently they took place, due to some limitations with our data capture tool. As far as the frequency of checks goes, twice daily was the overwhelmingly most selected check frequency. But again, it wasn't possible to say whether this mainly took place in the hospice or in the community. Remember though that 84% of these cases were in the hospice setting. Regarding adverse effects, none were documented in about 60% of cases, and the majority of patients who did experience adverse effects experienced dissociative side effects. If we group together the instances where confusion, hallucinations, vivid dreams and nightmares, and neuropsychiatric side effects were documented, we reach a total of 27% of all cases experiencing some form of dissociative side effect. Note that there were no urinary symptoms documented as having occurred. In terms of co-prescribing for those adverse effects, most co-prescribing was done at the time of starting ketamine, and the medications chosen here were exclusively haloperidol or a benzodiazepine, either on a regular or PRN basis. About 80% of cases required no further prescribing in response to adverse effects, and the small number of cases where further prescribing was needed, half received haloperidol. When this was given regularly, it was usually dosed at between 1.5 and 3 milligrams per 24 hours via CSCI, and when it was PRN, the most commonly selected dose range was 0.5 to 1.5 milligrams PRN. Our survey also asked about the prescribing behaviours in relation to the primary opioid in use at the start and during ketamine therapy. Remember that 90% of patients were taking an opioid at the start of treatment, and 75% of them were either taking oxycodone or morphine. About half underwent an opioid dose reduction of 10 to 30% in anticipation of reduced opioid requirements at the start of ketamine therapy, and a quarter underwent no opioid dose change. After starting ketamine, there were a variety of opioid dose increases and reductions over varying periods of time, and it wasn't possible to give reasons for these without more detailed clinical context. The intended course duration of ketamine was completed in 65% of cases, and where early discontinuation did occur, it was as commonly due to death or deterioration as it was to any adverse effects. Thinking again about 2012 Standard 2 and the use of patient-reported pain severity scores, a pain score was documented in 32% of cases. A patient opinion on the effectiveness of ketamine was documented in 56% of cases. Where a pain score was used, the most common sequelae of this was that the pain score reduced, and when the patient opinion was documented, the most commonly documented opinion was that the pain improved. From the healthcare professional's point of view, about 3/4 of healthcare professionals documented that pain appeared improved during treatment with ketamine. Very few ketamine dose conversions occurred, both from the oral to subcut route and vice versa. It wasn't possible to extract data on the conversion ratios used in the small number of cases where one did occur, but it was clear that a range of conversions were used. We thought it would be helpful to have a recommendation on the most appropriate conversion factor to use in our guidance, and we'll discuss that later. Moving finally to the post-treatment phase. Only 16% of cases were discharged on ketamine, amounting to just 10 cases in total. And of those, 70% were discharged on oral ketamine. 2012 Standard 5 recommends that if a patient is discharged on ketamine, the discharge letter should include a named contact and telephone number for further advice, and this was documented in 60% of cases. Standard 6 recommends that standardised information should be given to the patient, the GP, and the community pharmacist upon discharge, and there was generally lower adherence to this standard, although it was clear that the discharge letter was used as a means of communicating this documentation, and that occurred in about 40% of cases. The responsibility for the ongoing supply of ketamine after discharge was shared equally between hospice and hospital, and the most commonly occurring theme in the issues relating to the supply of ketamine were regarding whose responsibility it ought to be to continue that supply. And finally, 2012 Standard 7 recommends that patients discharged on ketamine, regardless of route, should have at least monthly follow-up with a specialist palliative care clinician experienced in the use of ketamine, and happily all patients discharged to the community on ketamine were followed up within 4 weeks of discharge. Thank you for sticking with me through the data. I'll pass you back to Penny to talk about the proposed standards and guidelines.
Thanks very much, Johnny. Just to mention as well, we're in quite a dark room here at the moment, so if you're failing to see us on the camera, then please let us know and we'll turn some extra lights on. So I'm going to take you through the main changes proposed, and on especially areas where we would like a bit of feedback today. I'm not going to go through the whole of the new guidelines, as I think that would take slightly too long. The guideline is still mainly based on level 4 evidence, as you probably guessed from our literature review. Our ultimate aim will be to add in a flow diagram summarising some of the sections in the guideline, which was something that was requested in the B-Box questions back in spring at the launch meeting, but we won't be able to do that until we have finalised some of the points. So we have made some changes to the general structure of the guideline to follow the journey from commencing ketamine to caring for patients on ketamine, converting or stopping ketamine, and to discharge and ongoing care. In the general principles section, we have added this statement. The evidence for the use of ketamine relevant to palliative care populations is focused on refractory cancer pain, as all of the evidence that we included in our review was in cancer patients, and is of mixed quality with mixed results. There is a potential for adverse effects and further research is needed. Ketamine should therefore be used with caution where standard analgesia with opioids and adjuvants has failed. Moving on to the regimens and doses section, so following on from the literature review and the guidance in the PCF, where burst ketamine has been removed as a regimen, and the advice from Cochrane, we've added in, so previously the 2012 guideline based on best evidence at the time recommended burst ketamine, but we've altered that statement to this top one, saying a burst ketamine regimen has often been used. However, the potential for adverse effects alongside publication of the study showing lack of effect compared to placebo mean considering lower dose titration has now been advised, which could be oral or via syringe driver. We've also added in a statement that once satisfactory analgesia is achieved with lower dose titration, ketamine can then be gradually withdrawn and may have ongoing benefit, and it can be repeated if needed. This is the first half of the regimens table. We have left burst ketamine in at the moment as an option, but we've moved it down below the lower dose titration via syringe driver and oral regimens. The changes that we've made are highlighted in purple, so you can see that apart from that, there haven't been many changes to the regimen table. This is the final part of the regimen table. So previously sublingual ketamine was included, but as we found no evidence for this and it seems to have disappeared from the other sources of guidance, we've removed it from the table. We have also removed the doses of the intravenous ketamine and altered the statement away from not being recommended without advice from specialists to from local pain services, as we felt that that would probably need to be the people involved if IV ketamine was being considered. To move on to monitoring, we've added the first statement that people should consider developing and using a formal care plan to aid with monitoring and documentation. And then we've converted the previous statements about monitoring into a table in the hope that this might be easier to make reference to. I guess the main part of this table that will probably need some further work is the initial dose titration phase. So we've left that as twice daily at the moment, but this very much was focused on burst ketamine previously, and as we could see from the audit results, there's a range of frequency of monitoring taking place, although we don't know which regimen that relates to. And I wonder whether we might need a couple of rows referring to the different regimens, as these might be felt to be different in terms of what monitoring would be appropriate. And that's an area that we would appreciate some feedback, if possible, today. Looking at the adjuvant medications, based on the current guidance in the PCF, and on the low level of evidence that we could find, we have expanded the range of benzodiazepines to include diazepam and lorazepam, and we have added in the potential for step doses as well as considering regular doses. These doses are as per the 2012 guidance and the PCF for the updated ones. There are a couple of them that are higher than some of the doses that we could see were used in the audit and also from our own experience. So for example, with haloperidol, often doses of 0.5 milligrams PRN and 1.5 in a syringe driver are used. So another area for potential feedback is kind of whether we alter these dose ranges to allow for that. Looking at converting ketamine, so as summarised by Andrew Dickman, this is complicated, and we have updated the recommendations based on his pharmacy input and also on the current guidance in the PCF, and there is a very low amount of evidence out there for this, but kind of taking that into account. So for oral to subcutaneous conversion, we have changed it from the previous 1-to-1 conversion ratio to it is advisable to commence the subcut ketamine as per the lower dose titration via syringe driver in table 4 and titrate as needed. So that's as if you were starting somebody on that from scratch. And then for the subcutaneous to oral conversion, as mentioned in our evidence summary, a conversion ratio of 1-to-1 has been suggested as safe as if within days of commencing ketamine, but in the couple of studies that there have been on this, they were patients who'd only been on subcutaneous ketamine for a short number of days and not a longer period of time. Otherwise, a conversion of 3:1 or 2:1 is advisable, and the 3:1 to 2:1 ratio is what was previously advised in the 2012 guidance. In the PCF, they talk about 1:1 if they've been on ketamine for days, and 3:1 or 2:1 if they've been on ketamine for weeks, but we felt that left a little bit of a no man's land in the middle. So we then added in the statement about avoiding abrupt discontinuation because of the risk of withdrawal effects. And then coming on to follow-up, so the previous guidance was following up within 4 weeks. Because of the different regimens, we have subdivided this further, and we have brought the review periods down based on group discussion. And based on our interpretation that a specialist palliative care clinician would include both medics and nurses, and what would be feasible and appropriate for the different regimens. Again, any feedback on this would be welcome. We have added in a statement that dose alterations should be undertaken after review by a specialist palliative care clinician with the involvement of a palliative medicine physician with the experience in the use of ketamine, and that the need for admission to an inpatient setting should be considered. So if we come back to the standards, we have currently only made changes to standard 2 and 7, and these are fairly minor changes. So we've added in conscious level to 2 for the checks that we feel should be recorded, and just change the wording slightly to hopefully make it more applicable to the different regimens. We've left this at the moment as rechecking observations twice daily, but based on the final decisions about monitoring, we acknowledge that this will likely need to be altered. And then for standard 7, we have changed that to 2 weeks in line with our changes to the guideline for follow-up, and also moved it to it being an agreed plan documented in the discharge letter to make it much easier for auditing next time. So as I mentioned, unfortunately our invited experts are not able to join us today, but they are preparing some feedback for us. And I will hand you over to Mary, who has some thoughts for us.
Thank you for inviting me today as the public representative. Listening to the guidelines, I can see that it's very comprehensive and there's a lot of work gone into it. So I've just got a couple of thoughts from the public point of view. I've sort of put myself into the shoes of the relative or carer really to make this a little bit easier to explain. I think it's absolutely imperative, but I know you have said this, that there is an information leaflet that is readily accessible and easily understood by the relative or the carer. And I wondered if there'd be an opportunity for whoever would be deemed the best person to do this, to go through that information leaflet with the patient and carer when the patient's discharged. And then there's hopefully a good understanding from their point of view of when they need to report back any concerns. The next point that I thought about was point of contact, because as we know, things get very fraught in the small wee hours very often, and that's when problems probably tend to occur, I would think. And I was wondering who would the relative or carer contact at that time? I understand that there is the district nursing service is a 24-hour service, but would the district nurse, without trying to demise her in any way, her or him, be able to give me the advice I needed at that point if there were any problems? And so I'm thinking particularly during the working hours, it's more easily, I'm sure, to access that advice, but I'm thinking particularly around the out of hours. And the third thought that came into my mind was that we've talked a lot about expert advice, and feel as a relative or a carer, I might need that expert advice. And would I have access to that very readily, or would I have to go through channels before I got that, just so that if there were problems, I could make that alert to yourselves as well. Thank you very much.
Thank you. So thank you very much, Mary. I think those are important points and that we'll need to be considering closely as we develop the guidance further. So I've just put a couple of discussion points here from our point of view that it would be helpful to have some feedback on, and I've highlighted most of them, I think, as we've gone through. But I'm aware that we're running a bit short of time, so if we can open up to some discussion, if I can ask my group, maybe if we gather around the table a little bit, just so that we're able to be heard if we're responding to any of the questions.
Okay, thanks, Penny, for that presentation. It was great, and to fit that much in that amount of time is really impressive. We've been having some problems with the chat, I believe. I don't know if Alison's there as well in terms of seeing any comments that have come through. So I'm not sure we're able to do that at the moment. Alison, is there any questions you have to start with?
Hi, just firstly to say thanks very much to the GDG. I think that's a huge amount of work and just fascinating what you've discovered, and also great to see 79 cases in the case audit. So well done to the GDG, and well done to everybody for submitting these cases for review in the middle of what's been a really difficult year. So as Tom mentioned, the Q&A is I've been wittering away on the Q&A, but nobody's been able to talk back to me. So I know there will be lots and lots of questions out there, but we're struggling to see them very clearly. There's just Seamus from Clatterbridge has come on and said, you know, it's a great presentation as well. So it may be that some people now are able to put their questions on, but I think we'll just have to carry on without that for the moment, for the remaining 7 minutes. So it'd be really interesting to hear from the GDG about these discussion points and what you've been thinking about each of them.
Okay, so I guess for the first point, in terms of still having ketamine in the table as a choice of regimen, it's probably partly because it felt like a large leap to go from burst therapy being in wide use in the region to it not existing in the guidance at all, and also in terms of whether everywhere would feel comfortable changing their practice if they are currently using burst ketamine, and whether that needed to be a bit more of a gradual kind of discussion and potential shift to kind of trying other regimens and becoming familiar with different regimens. And I know that will likely vary across the region. I don't know if anybody else in the group has anything they want to add to that.
Yeah, I think I would agree. It's first ketamine's the regimen that we're probably all most familiar with, and 2012 was almost 10 years ago, and that's what this entire time we've sort of been thought had the most evidence for. So I think to remove it completely would be a big jump.
I guess the issue with that is that the reference for it, the source for those doses in our table, no longer exists. So it would be referenced as expert opinion, and I guess that is the point that makes me feel slightly more uncomfortable about it, I guess, but we probably need to check the temperature of the region as a whole as to opinions on this, I think, to move further on that point. We don't want to be making decisions that affect kind of or everyone in the region or cause any panic.
But also we don't want to be recommending something which there is no evidence, and in fact there's some evidence of significant harm.
Yes, I guess the point to make about the Hardy review as well is that they weren't on any preemptive adjuvant medications such as haloperidol. So I know widely we do tend to start some adjuvant medications if people are on burst ketamine in particular. So I guess I would hope that that might have affected the side effects if those patients had been on it from the beginning, but we don't have evidence really for that.
And happily, in the cases that we looked at, there were no reports of serious, long-lasting adverse effects such as the much feared urinary complications.
So we just had a comment. Seamus is one of the few people I think who can post on the Q&A, but I guess you could word the guidelines to say, you know, we're aware that this is common practice, but and that might encourage people to change what they do. But Seamus agrees with the GDG. He says we're moving away from burst ketamine, but he says perhaps there's no harm in keeping it in with a kind of proviso that this isn't evidence-based, because you're right, it does take time to change practice.
And I guess that's what we hoped, that having a statement about it, but then keeping it in the table in the lower position might be a balance between the two. And the wording of that statement can be changed to be more or less forceful as needed.
Okay, I think that's really helpful, and I'm sure I see that you've got your email on these discussion points, and we will get them posted. So hopefully there'll be some more feedback. Do you want to move on to number 2? Just before you do, Claire Finnegan, she's just saying the scope for confusion. I guess that's about how you word the guidelines, though, isn't it, Penny?
Yes. And I know obviously it comes to yourselves at the subgroup as well, and we'll get advice back from the invited expert and the external expert, and I think there is tightening up that can be done on the wording as it goes through that process to make it as little confusing as possible.
So I think they're just coming back at me now. It's all starting to flood in, as it always does, with 2 minutes to go. I think there's a thought that perhaps there might be confusion with 2 regime, and if Claire's saying if the evidence in favour of the new regime is strong, we should include that. But you will do, won't you? That will be clear from the level of evidence that you'll have against the lower dose, the lower titration regime.
Yes. Yes.
And just so you know, Andrea Graham's joined us from St Luke's Hospice. Fascinating piece of work, and saying thank you to the GGG. And she's just saying about, is there a role for developing a regional or a national patient information leaflet for patients, which I get. Yeah, so on the Scottish palliative care guidelines, they do actually have a patient information leaflet there, which I haven't looked at in detail except to see that it's there, and I guess that could probably be used as a basis for a leaflet. I guess the difficulty of doing a regional one is trying to make it applicable to all of the different areas, which we're quite set up quite differently now, with some places having impact, other places not, for example. So it's definitely something we can look at, but it might be that it's the basic leaflet, and people will need to kind of add relevant information to it. Thanks. There's just a question from Seamus about your point 2, and he's saying what observation should be done, and I guess frequency as well, for people who are having ketamine but attending outpatients.
So I guess in the table that we've done at the moment, they would that would be after this, your kind of initial commencement and titration phase, and this is where it becomes complicated. So at Marie Curie currently, the main use of ketamine has been burst ketamine, and that's partly why it's been difficult to make strong recommendations about the observations, etc., for the other regimens, because I think there might be other areas in the region that are able to have a bit more experience in them that would be able to help. So I guess what we've done in the table at the moment is try and divide it into people who are having kind of that initial dose titration as an inpatient, and then people who are on more stable dosing, or people who are having kind of subsequent dose titrations, which are probably more intermittent, and I would imagine a bit more cautious if people are at home. And as I said, I think there will need to be some extra rows in that table, but that's as far as our group discussions had got at this point. So if you have any suggestions, then they'd be welcome.
Penny, we also mentioned as well, didn't we, about patients who may be on a ketamine drug at end of life because they've converted over, and we wouldn't be doing observations on that group of patients. Yeah.
I think it's just one final point, because I'm just aware that it's 1 minute past 2 and people will be dashing off. But Claire from Southport is just saying about the role of the non-medical prescriber and asking about roles and responsibilities. Do they lie with the individual?
I think that's a very good question. It's not one that I feel able to.
No, I should imagine it
to answer.
Prescribe,
but yes.
Yeah, I think it's totally down to the prescriber's discretion. I know I wouldn't be comfortable just prescribing ketamine or increasing it. I would go through my consultants first.
Yeah, same here. I'd do the same, but I think, as Siobhan said, the responsibility would still be with the prescriber.
And she then goes on to say, do roles lie with individual organisations rather than collaborative, and that it might need some discussion between the steering group and the GGG, but I guess that's in the wording of the guideline, isn't it?
Yes.
Yeah, and I don't think we're in a position to be too prescriptive with exactly what people do. So it will be very much guidelines and standards that can be tailored to the individual organisation.
Okay, well, listen, I'm going to hand back to, I think we've come to the end of the discussion section. We know that there isn't enough time for discussion in these hour-long sessions. So in 2022, you'll be delighted to know that we'll be extending collaborative back to the hour and a half that it used to be when we all used to meet live. But just to say a big thank you from me to the GDG. You've done an amazing job with this topic, and I'm just going to hand back to Tom now to see us out.
You're on mute, Tom.
There we go. One last hitch. So I'm saying I've not got too much more to add other than saying happy Christmas to everyone and encouraging anyone to send further feedback to Penny. This session has been recorded because I know that some people maybe missed the start or came in at different points. So there's opportunities to watch back different parts of it, and to encourage colleagues who may not have been able to get on or whatever to watch it. I'm sure Penny will be delighted for any further comments that come in with time. We can pass them on to us as well. So the next meeting will be in March, but look out for plenty of updates in the meantime before that. And have a good Christmas, everybody. Bye bye.